Mr. President. My part in the joint session is to present take-home messages. The first presentation was paravalvular leg closure, indications, techniques, and outcomes. This procedure concerns severe patients in cardiac heart failure and or hemolytic anemia with high surgical risk. And this procedure must be exercised in experienced centers because it's long and complex with multiple devices. Teamwork will select the right patients. Preparation of the procedure includes efficient imaging of the leg with 3D TEE and CT, and precise location, size, shape, severity, and number of leaks. This imaging allows to prepare the materials, choice of devices and sheets. During the procedure, access can be transseptal, transfemoral, and rarely transapical because complications. Crossing the defect with 3D TEE important step. Then release of the device must avoid interference with valve leaflets. We have risk of failures, 10%, and complications are valve interference, stroke, hemolysis, and embolized device. But this procedure is more safe than surgery. The second presentation was management of percutaneous interventions in high bleeding risk patients. Development of new generation of DES permits shortening of the DAPT during high bleeding risk patients. We prefer radial access. Gastrointestinal protection is systematically prescribed, and clopidogrel is recommended. We have 3 clinical situations. The first one is PCI and chronic coronary syndrome in high bleeding risk patients. We prescribe 1 to 3 months DAPT, then long-term single therapy. The second one is PCI and acute coronary syndrome in this population. We give us 6 months DAPT, then long-term single therapy. And the last one situation is PCI and atrial fibrillation in high bleeding risk patients. Prescribe 6 months NOAC and 1 antiplatelet, then long-term NOAC. Next slide concerns latest innovations and new indications of TAVI. TAVI is now the gold standard to treat severe aortic stenosis. This is the optimal choice for degenerated prosthetic valves. Expanded indications being evaluated, like asymptomatic aortic stenosis. Experienced operators are required. Current results show high success rates and low morbid mortality, and improved devices are always being developed. But pending issues with TAVI are needing for pacemaker, stroke, and vascular complication. Yet, some questions remain regarding anticoagulation after TAVI and coronary access after TAVI. Finally, long-term follow-up is not yet available. The last presentation was PCI for CTO, current indications and techniques. Appropriate indication of CTO PCI is essential to maximize benefit for the patient. The 4 cornerstones of success of CTO are patient's demographics, lesions characteristics, operator expertise, and availability of materials. Success of the procedure makes a lot of difference compared to failure, impacts considerably the outcome. Thank you for your attention.